So this is the ASIS, anterior superior iliac spine, right there of the front of the hip or pelvis, and that's kind of my landmark to know where I'm starting. And my finger is 17 millimeters wide. I know because we had to measure it when I was in my training. So I come that far down, and then I come over a couple centimeters, and then a ruler, and then I'm gonna make a 9.5 or 10 centimeter incision here. Right there, 9.5, and that is centered over the tensor fascia muscle. You can see right there. That's the tensor fascia. So now we're just gonna cut it and go for it. Through the skin, and under the skin is the sub-Q. You know all this. You took anatomy. And so I'm gonna just take my electric knife, and it goes right through this layer. And I'm gonna get down to through some of this is like stuff they call Scarpa's fascia and all that, down to the tensor fascia and the muscle of it. And you can see the muscle pink underneath the fascia. So I'm just gonna mobilize this, talk a little distal a little bit so I can see. And then I'm gonna take the fascia off of the muscle, just like that. And that gets me access now down towards the hip. And I'm gonna take a cobra. Oh yeah. So I'm gonna put in a retractor so I can retract the tissue so I can see Richardson. And then a tonsil. And remember I was telling you before about the circumflex vessel? Yeah. So I can't get to the medial ones that go up the back of the femur from here. And those are the ones that are important for the blood flow to the femoral head. But I can actually see the lateral ones through this incision. And they are in my way to get down to the hip. And so all I'm doing is dissecting around them to free them up. And then I'm going to use this bipolar tool right here. And I'm going to coagulate them. She doesn't need them anymore because we're getting rid of her hip. And this just helps limit bleeding during surgery, which we don't want. Well, bleeding's okay to a certain degree. Otherwise, up there starts to get kind of nervous. Okay. So then I'm going to go through those vessels with this electric knife to free them up and move them out of the way now.
Move it or lose it, sister!
So now I've got the tensor fascia in this finger, and right next to it, right here, is the rectus femoris, right? Part of the quad. I'm going to go underneath the rectus. And now I have one of these retractors on the medial femoral neck and one on the lateral femoral neck. And that allows me to see the front of the hip. And this is a little self-retaining retractor. You probably can't quite see inside here already, but you can imagine. And I'm going to show you some stuff here in a minute. So now I'm just going to try to, again, contain any bleeding. And then I'll take a long pickup if you have one. And the next step is I'm going to remove some of the bursa or kind of fatty tissue that's in front of the hip capsule. The iliofemoral ligaments, right? Remember that part? Probably not.
Got him!
There's too many of them and they're not really named well, or they're not really like defined well. They just kind of all coalesce to form the hip capsule. But this allows me now to get down to the hip joint. And now I'm going to take my electric knife and I'm going to open up the ligaments of the capsule in an inverted T so that way I can see into the joint to be able to do the replacement. I got to be able to get all the way down to the femur here. Doing okay? Yeah. Okay, good. So I'm gonna use a stitch in a second, maybe a 0 or a 1. We use a lot of sutures in the OR. This is a dissolvable suture, and it's a sugar polymer, a really complex sugar polymer. That's how it dissolves over time. It takes like 2 months to dissolve. I'm just using this as a temporary tool as a little retractor because I cut that capsule or ligament, and I'm just putting this in here so I can pull on it to move it out of the way. I take the snap. And so I hold this now. This helps me just kind of keep it out of the way while I finish opening up the joint to see the whole hip inside. Okay. Then once I've done that, now these retractors go inside the joint because I've opened it. And again, you can't see it from where you are, but I'll show you here something cool in a second. It's about damn time. Yeah, I'm looking right at the femoral neck. And in order to get the ball out of there, I can see the fracture and everything. But in order to get the ball out of there, I've got to cut some of that bone. So I'm going to take a saw, battery powered, just like what you use building a house, and I'm going to cut some of the bone here. So I cut that. Let me have a closer. So this is part of the femoral neck. This is the part that I cut, and this is a fracture right there. Oh, wow. So I removed that, just out of my way. I already have the traction on the growth, but I want to put on some fine traction, so I want you to take the crank out of there and go 3 turns clockwise.
3, 1, 2, and 3.
Pulling the leg, and then I want you to unlock rotation at the top and turn the propeller towards me to 60.
60. 60.
If you want to get a cork out of a wine bottle, I don't drink wine, right? But if you want to get a cork out of a wine bottle, they have a corkscrew. We have one to get the femoral head out of the hip. Because it's stuck way in there. How else do we get it out? So this literally goes down into the bone, okay? And then it spins the head free. And then we have a T handle that attaches to the tool. And then I can use this to pull, and hopefully, we have enough fight in there to get that thing out of there. There we go. To pull the femoral head up. There it is. So that's the broken hip ball, and you can see where the fracture was.
Yeah.
And the retinacular vessels, you can't see them on here because they're disrupted, but they're in this tissue right here. This would have been the retinacular vessels of the blood flow to the, so you can see they're gone. This is the ligamentum teres. Remember that?
Yeah.
In children, that's like 25% of the blood flow to the hip. In adults, less than 5%. It does nothing. So when these are torn, it's dead. So now we just need to know what size it is. And so the easiest thing to do is get these little trays that say what the numbers are that I can't read.
Yeah, it looks small.
So that's 42, no. 43, no. You have the next one? Oh, wait.
Yeah, I do what you want.
44, no. 45, yes. Go through a 45. It doesn't go through a 44, so I do a 44.
44. Okay, so the first one doesn't go through.
Correct.
All right, cool.
Now go counterclockwise the 3 turns on the traction.
Where?
Go counterclockwise the 3 on the very end.
Oh, there's like a...
Yeah, counter. And then unlock the growth traction down here. And then unlock the rotation lock. And go to 120 towards me. Yep. So we're just setting up the femur now for me to get access to the femur because we got that out. Now drop the foot down to the floor. So this is where this table really helps me. So down and under, yep, you can lock it there. And then I have an attachment here and this little lift tool that I can put underneath the femur, and then I can control the femur. And this is where you're going to be able to see some stuff, I think. So let me have you down here. Is that crazy? Pretty cool, huh? Okay, good. All right, so now I'm going to put in some retractors around the femur. So that way I can see the femur. And I've got to release a little bit more of the capsule or ligaments. I think the long finger took up. There's some bone debris in here from where the fracture happened. These are just little pieces from where the fracture was. So we get rid of that. Don't need that stuff. And then, and then I'm gonna release or let the lab. This is the lateral capsule of the hip, and it is the attachments of those ligaments along the outer portion or lateral neck of the femur. I'm just releasing them off the femur so that way the femur can pull away from the pelvis a little bit more to let me do what I need to do here. And then I can use the lift tool here to help raise this up so I can see it even better. I'll get the mat. Different tool. So what this does now is it allows me to bring the femur up to a point that
Today, Junior!
that I can work on it on the inside, if you will. All right, I don't know. Can you see it up in there from where you are? So this is the upper part of the femur.
Oh, yeah.
This is where I cut it. Okay? And this is the vastus lateralis. And so we've got all that stuff out of the way. Now I have access to the femur, and I can literally get inside the marrow space of the femur. And her bone is so soft that I can almost do it with this plastic suction tip. And so now what I'm going to do is I'm going to open it up a little bit, just by biting away some of this extra bone on the outside, the lateral neck. And then we have tools that are shaped like the hip implant that's going to go in the femur. These are shaped just like the implant. Different sizes, and these literally just go down inside the femur, and it just prepares the bone to receive the new hip implant. Is that crazy?
Yeah.
So this is the part that's probably good that the patient's asleep. So literally these just go in and they size up until I fill up the femur for the right size. And it's kind of a feel thing, an experience thing to know when is it the right size. I think I got one more, maybe.
Well,
We're going to do the planar neck. So it's flush with the top of that brooch is what I call it, that implant that I impacted in there. So now if I look at the top of my femur, you can kind of see here the implant that's in there, and it comes flush to the top of the femur. Now what we're going to do is put on, this part is modular. All this stuff we're doing is little, this is the neck part. You know, in the final implant, it's all one piece. But this, we just have lots of different sizes and stuff so we can try to see if it's the right one, right? So we put that in. This is not the final product, it's a small ball. So it's just easier to get in and out because the small one to curve. We're gonna bring the leg up. So go ahead and bring it on up so parallel to the other one. And lock that. Okay, good. Then what we're gonna do is pull and lock the growth traction.
Lock it there.
Okay, yep. And then give me 3 turns clockwise.
Alright. 1, 2, 3.
And then I want you to rotate it to 0.
Rotate the 0.
And now we put the hip back in the socket and then lock that there.
Let's all go to the lobby. Let's all go to the lobby.
Dear God, it's beautiful.
You're right in the right ballpark of that. Go ahead. At 120, you can lock that. Unwind your 3 turns of traction counterclockwise.
1, 2, 3.
And then unlock the growth.
Rotate.
Okay, and then you can drop her back down and under. Take the mirror. I think Ada.
What's the matter, baby? Nothing, sugar. What's the matter with you?
I can do that.
KA12.
Yep.
We have a 44 big head, and then the 28 1.5 metal small head.
Perfect. We definitely won't go longer.
31 and 31. What?
We definitely won't go longer.
Yeah, no. Alright, we'll open all of them up.
So now, again, you can see the implant fills up the femur, right? To B, and this stem is usually 43, and that's right at 43. That just tells me when I put the next one in that it went in the same place.
Okay.
So now I take out the trial. We call this trial. We call this a brooch.
Okay.
This is what it's called. The marrow space is hollow. Everybody's worried about the marrow, but they don't know medicine.
Tell us how you really feel.
You know what? I'll tell you how I really feel.
The truth is that bone marrow in your long bone, like in your femur, after age 25, doesn't do much. Most of it comes from your pelvis and your spine.
Okay.
So we can work on this bone marrow like this and move it out of the way and open it up, and it causes no problems at all. But all my patients are worried. What's going to happen to my bone marrow? Then they just know to ask, but they don't know what it means. You know.
Yeah.
Lock there.
So this is antibiotic powder,
That's one.
vancomycin antibiotic. We put this in there to help reduce the risk of infection.
Take that out, put that in, put it back in.
So we put a little bit inside the femur
Yeah.
next to the implant. This is the real thing.
Okay.
So you can see it's one piece. It's the same size as what I just took out. It's got rigid, so it'll grab onto the bone, and it's coated with a coating called
No,
hydroxy apatite.
I haven't seen one of these in
I
action.
don't know if they teach this in anatomy, but the inorganic matrix of bone is 85% hydroxy
Okay.
apatite,
Yeah.
which is a calcium phosphate, whatever it's called. So that the bone likes this, and it'll grow onto it and heal through it. So we're gonna put this in here into the femur, just like such. And there's an inserter handle. And we just push this down in until it goes, and then we finish it with the mallet. And make a mat. Let me have a ruler. And then I'm going to measure to see if I'm close on my height. I'm around 44. So let me see the impactor one more time. So I'm setting up maybe 1. We'll give it a little bit more.
This just in.
What are you?
An idiot sandwich.
Idiot sandwich what?
An idiot sandwich, Chef Ramsay.
All right. So let me get the pitch out. And then you bring the leg up. So then we're going to pull and lock the gross traction. Good. And then we're going to do 2 turns clockwise. And then we're going to rotate into 0. Okay, good. Hang tight there for 1 second. All right, then we go counterclockwise. Yep. It's all undone. All right, then unlock the gross. Yeah, that's fine. Yep, you did. All right, come on in with X-ray.
Thanks for watching this point of view breakdown. We have numerous surgical videos in the works right now. Make sure to subscribe to the channel to stay updated with our orthopedic trauma OR.